this analysis was born after there are important unmet needs in the field of muscle-invasive bladder cancer. We know that cisplatin-based chemotherapy has represented the standard of care, but for cisplatin-eligible patients only. And there are many attempts to try to find also valuable option in the neoadjuvant setting for those patients who are ineligible for cisplatin. In this sense, our group with Professor Necchi conducted one of the first trial, which is the phase 2 PER-01 trial, using an immune checkpoint inhibitor, Pembrolizumab, in the neoadjuvant setting. This is not an option that gained the reimbursement in many patients, whereas recently the results that were also already presented at ESMO, but have just been published from the EV303 trial, demonstrated that the use of enfortumab vedotin plus pembrolizumab in the perioperative setting could increase the overall survival, the relapse of these, reduce the relapse of these patients, and increase the pathological complete response. However, in this kind of trials, it's not well known how much enfortumab adds to the pembrolizumab, and we don't know the real contribution of the neoadjuvant compared to the adjuvant phase. Therefore, we decided to perform an IPD level based meta-analysis, an IPD comparison of patients, cisplatin-ineligible patients with muscle-invasive bladder cancer treated with EV3 plus Pembro in the EV303 trials versus pembrolizumab in the PER-01. This is a validated statistical approach, but of course it's not meant as a statistical comparison, but only a graphical and visual representation comparing the arm of EV-Pembro in the EV303 trial with the arm of pembrolizumab, of course, in the PER-01 trial, just to provoke the design of trials which will stratify patients and then which will study specifically the different contribution of the drugs. We know, for example, that the EV303 trial at the beginning it included also the Pembro monotherapy arm, but the arm was closed. This arm was closed in 2022, so we don't really know which was the added contribution of enfortumab to pembrolizumab. That's why we tried to compare these two different trials. This is a very, very good question. Of course, we should have a biomarker and we should have patients' characteristics, but at the moment we have no such data. And I think that in the future, biomarker analysis such as ctDNA, utDNA will be very useful to understand which kind of patients are most likely to benefit from this combination in the perioperative setting. Of course, this is an important trial. In my opinion, the EV303 is a practice-changing trial. This is the area in which we will try with a perioperative approach all the patients independently from cisplatin-ineligible. We just saw the results of the EV304 trial here at ASCO GU 2026. But at the moment we don't know the contribution of the single agents. Of course, this is an important trial because 2 out of 3 patients had a pathological complete response. These insights are very useful, for example, to design bladder-sparing approaches for the future. These are 2 very different trials. These are 2 different levels of trial. The EV303 is a randomized phase 3 trial. 2 out of 3 patients has a pathological complete response. 3 out of 4 patients are alive after 5 years. So these are massive improvements in survival. In the PER-01, around 39% of patients had a pathological complete response, and there was a good overall survival after 5 years. But this is a single-arm phase 2 trials. The two patients population are quite different. For example, in the EV303 trials, there were more T3 to T4 tumors there were the lymph node positive patients. So there are two different levels, and I think that the use of perioperative EV-Pembro is fundamental in this population. However, we should try to find which are the role of enfortumab added to Pembro, but also of the adjuvant enfortumab plus pembrolizumab. I think, first of all, to understand if we can spare bladder, so if with these higher pathological complete response rates, we can design bladder sparing approaches. Our group is working so much with the bladder sparing studies and approaches. So I think this could be the future, because we should offer to our patients not offer a good survival, but also a good quality of life. And radical cystectomy is a very complicated procedure with many post-surgical complications and also altering our patients' quality of life. Besides these approaches, I think that an important step forward this to treat well this kind of patients should be the biomarker analysis. In this setting, not only to try to find which patients will benefit more from EV plus Pembro, but also to find if there is the possibility to personalize the post-operative approach. So you will start EV Pembro, but for example, studying the ctDNA and utDNA, also to understand if there is the possibility to de-intensify some of these agents in the adjuvant setting. So there will be a lot of interest and a lot of research in this setting.